Welcome everyone. My name's Anneke Lucassen and I'm Director of the Centre for Personalised Medicine here in Oxford, which is a partnership between St Anne's College, that you find yourselves in, the Wellcome Trust Centre for Human Genetics, and then Wellcome Trust Centre for Human Genetics is part of Nuffield Department of Medicine. And today, I'm so pleased that this meeting is finally happening. Thank you so much, particularly to Porrig, where is he, to persisting with the organisation of this after its initial cancelling, and of course all the other excellent JRFs and particularly Kath and Thea who've been really involved in organising this, and thank you to Cambridge Prisms for their generous sponsorship. I think Jess, Letitia and Anna from the journal are all here. The new journal Precision Medicine kindly sponsored this particular meeting. So today's meeting is all about trying to find a common ground for constructive debate around the issues raised by measuring polygenic risk. Why now? Why do we want to do that now? Well, like so many other subjects, be that mask wearing during COVID or vaccine hesitancy or enthusiasm, the debate around technological developments easily gets polarised into pros and cons, for and against, enthusiasts or Luddites. And our thinking was that if we could find the common ground that we share between those polarisations and inhabit that better, then we're more likely to understand the extremes of the debate also. We've known for many years, of course, that common diseases have multifactorial etiologies, usually a combination of genetic factors, environmental and lifestyle factors, as well as random factors such as the development of our immune system. But it's only relatively recently that genetic technologies have been quick and cheap enough to routinely map the genetic component of risk to such diseases. Genetics in the clinic has very much focused on the rare single gene high-risk contribution to disease, so cystic fibrosis, muscular dystrophy, your BRCA1 or 2 gene carriers. And this newer technological advance that allows us to measure the contribution of the remaining contribution to common diseases is relatively new in practice. And I think there's much enthusiasm about being able to determine that, and how that might help in tailoring screening information or lifestyle advice. And I would say that I have found myself in both sides of the camp at different stages of my career, both as a tech enthusiast, but also as a bit more of a Luddite. After 4 years in the lab analysing susceptibility factors to common diseases such as diabetes, I wrote very confidently in my PhD thesis that the technological challenges of mapping factors involved in common polygenic diseases is rapidly being met. And once these risk factors have been identified, screening tests could rapidly be transferred to the clinical setting. So I think you'll agree that's a real sort of polygenic enthusiast stance. But I did find that in the clinic that was much harder to do in practice, and that's some of the things that we want to talk about today. I've also found myself being an advocate of treating a genome as a resource, so collecting a sample once in a lifetime and using it to predict and refine risk of many different diseases over time, and seeing that as an advantage. And also thinking of it as just another biomarker, so the argument being that if we use cholesterol and blood pressure measurements to assess cardiovascular risk, then why not try and improve that with polygenic risk scores? So that's, I would say, one side of an argument. And in the CPM, the Centre for Personalised Medicine, we made an animation, albeit before my time here, but about polygenic risk scores that is available on the website. And that says, as part of the animation, imagine you knew you were at high risk of developing a heart attack. That's pretty clear motivation to do something about it. How would you know? A major risk factor for common diseases is our own genetic code. So we can have a debate about how, if that really is such a clear motivation and what would we do about it, but that's how we summarised aspects of polygenic risk. But of course, for most of these diseases, polygenic scores contribute only a small proportion to the total risk. So knowing whether you're high or low polygenic risk may say relatively little about your absolute risk of disease. So in our animation, we talked about a total risk, but suggested that knowing about your polygenic risk would tell you whether you're going to develop the disease or not. And of course, that's part of the shortcut that we must avoid in this discussion, because actually, for all those common diseases, so that's heart disease, cancer, and diabetes, broadly speaking, the polygenic risk component is about 20% of the entire susceptibility component. So if you compare low versus high polygenic risk, you might find a several-fold difference, and that might sound very appealing as an intervention or for an intervention, but actually the total amount of risk difference that you can make to the absolute risk is relatively limited because of other risk factors at play. And so, you know, what might we expect from polygenic risk scores that are different perhaps to blood pressure, cholesterol, other biomarkers that we're more used to? And I think one thing that we really need to bear in mind is that the discourses around genetics have been rather and remain rather deterministic, with an expectation that if only were we to refine the technology further, get it cheaper and quicker, that clear findings would leap out of the genetic code, that we'd be able to look at the genetic code and hold a magnifying glass to it and know what we were predisposed to. And that might, of course, stem in part from our understanding of genetics of single gene high-risk conditions, such as cystic fibrosis, as I mentioned before, and that people have translated one to the next, perhaps inappropriately. So that's why I think it's so important to have this discussion today, so that we can really be realistic about our expectations for polygenic risk scores. And so, unlike other factors that might subtly nudge a person's risk one way or another, people might read more into genetic test results than they do into, say, a blood pressure measurement. And interestingly, when we had discussions with our PPIE, public patient involvement and engagement group, a strong bit of feedback that we got from them was that if we're going to call them polygenic risk scores, then that they would assume that says something very clear about risk rather than something rather subtle about risk. And we tried to summarise some of that in a recent BMJ paper. I think most of the authors are in the room today, so that's great. Where we really try to begin to inhabit that middle ground so that we could have a discussion about the opportunities and limitations of polygenic scores or polygenic risk scores. We said we must not let enthusiasm around polygenic scores allow us to forget other factors that are bigger, more modifiable and relevant for everyone. But even that, although I think we worked very hard to make it sound reasonable, there were various people who thought they were being too negative and like Luddites about polygenic risk scores. So I think I'm hoping that for discussion today, amongst other things, we will come out this idea that we need to be very clear about absolute risks rather than relative risks. The appeal of polygenic risks has often been couched in terms of big difference in relative risks. But if we look, say, for common cancers, and we listed this in our recent BMJ paper, that the lifetime risk of breast cancer, if you're in the top 5% for polygenic risk scores, would be 19% compared to a population risk of 11.8%. So on one hand, you might say, well, that's quite a significant difference, but that's only for the top 5%. And I think that's quite a lot less than some of the people, certainly in our PPIE group, expected a polygenic risk would be able to tell them. And for ovarian cancer, pick 2 female cancers there, but the lifetime risk for the general population is 1.6%, and your top 5% of polygenic risk changes that to an absolute risk of 2.1%. So I think very important to put those sort of figures into a context. And then I hope this will come out in discussions also that we must consider the population in which a polygenic risk score is designed. So variants used in polygenic scores are overwhelmingly from European GWAS analyses. So 95% of the studies looking at common variations throughout the genetic code are on people of European or Northern European ancestry, and scores have lower predictive accuracy when applied to people with non-European ancestry. And that runs a real risk of widening inequities unless we do something about that. And I would say that we've had calls for improving diversity in our genetic collections, but despite that, the inequities have increased rather than improved. And the other thing, of course, that's relevant about our population is, for example, the age in which we're studying or setting up the polygenic risk score. So if we're designing a polygenic risk score in a population of 70-year-olds, then we mustn't assume it's going to be immediately relevant to someone who has that test at the age of 30, 40, or perhaps even as a newborn, or horrifically, as we might all agree, some direct-to-consumer companies are now offering that as a pre-implantation genetic test for polygenic diseases for adult onset. So before I lead on to our first set of speakers, I would summarise that for most common diseases, unglamorous but well-established risk factors for smoking, obesity, socioeconomic deprivation matter more than a person's genetic background. By that, I don't mean to say that I want to dismiss someone's genetic background as not being relevant, but we must pay attention to these more unglamorous factors if we're going to introduce polygenic risk scores at scale in predicting future ill health. So that's my introduction. As I say, welcome again, and I'm going to go straight into the first session. We'll have a short break after that session, and we're going to start with 3 different short talks about different conditions, and then after the break we'll have a discussion that'll be chaired by Claire.